So after listening to Professor Jhanji and Professor Coy about the use of corneal biomechanical properties in the diagnosis of keratoconus, I'm going to talk about how we can combine the use of topography and also biomechanical assessment before we consider any patient for refractive surgeries. So we know that if we encounter one corneal ectasia after refractive surgery, it is a nightmare. And studies have shown that abnormal preoperative topography is the most significant factors with the highest relative risk. And we all know that keratoconus is a progressive disease, and the posterior cornea and also the pachymetry are usually the first few parameters that changes early in the disease. And the rotating strong flux imaging actually provides a very useful information on the tomographical data for diagnosing early attended case. So this is the BAD we all familiar with. So this patient have all the D get wet. And so the BAD will actually evaluate the front part of the cornea, the back part of the cornea, the change of the cornea thickness, and the ART max, and also the thinness point. And it has an enhanced BFS, which actually different from a normal BFS. It excludes the center part of the cone so that it increases the sensitivity of the topography. And the corneal thickness spatial map actually is a representation of how the corneal thickness change starting from the center of the cornea. And another important parameter is called the Ambrosio relational thickness. It has been shown to have a very high sensitivity and specificity in discriminating keratoconus from normal cornea. And therefore, we have 5 parameters: the DF, DB, DP, DT, and DA. And finally, it will give you a bad D. And those values are color-coded and with suspicion being yellow within 1.6 to 2.6 standard deviation from normal, and pathological value will be indicated in red color. And as we all mentioned about the form flux keratoconus, it actually was defined as a cornea that has no abnormal clinical and corneal tomographical findings, but with a fellow eyes of clinical KC. And studies have actually shown that some of the other topometric parameter actually is able to differentiate fellow eyes of a unilateral keratoconus from normal, but not the BAD and ART. And previously in Chinese University of Hong Kong, we find that the final D values of the BAD had a high AUC of 0.76 for detecting the form flux case with a sensitivity of 53% and a specificity of 80%. And as Professor Jhanji mentioned about the corneal biomechanical properties, so because we know that corneal biomechanical failure is the basis of keratoconus, and so therefore the ability to quantify these properties is an important step for early detection of the disease, and actually COVA stands for the corneal visualization strong flux technology. And we utilize the new softwares from the COVAs, and we identified 2 parameters, which is the DA ratio 2 and DA ratio 1, which show a very high AUC of more than 0.93 in differentiating keratoconus from normal. And we find that the diagnostic capacity are comparable between biomechanical properties and also topography. Later on, a new parameter, which is called the stiffness parameter, was developed. It was intended to develop a parameter that is independent on the intraocular pressure, because we all know that intraocular pressure of the eye will affect the measurement of the biomechanical properties of the cornea. And later on, the Vincent-Kura group developed a screening report, as mentioned by previously, and one index called the CBI, the COVAS Biomechanical Index. So it involves different indexes, and it will give you generate a COVAS Biomechanical Index at the end. And so this is the graphical representation of what these parameter means. So for soft cornea, usually you will have a higher value of DA ratio, higher value of integrated radius, a lower value of ART-H, and also a low value of SBA1, the stiffness parameter. And in the literature, the Vishal group reported a high AUC of using the CBI in determining keratoconus from normal, and we also find a similar high AUC in our group, in our data. And later on, we conduct a comparative study using the corneal dynamic and tomographic analysis in those with form focused keratoconus compared to normal eyes. And we find that the AUC between the CBI and the BAD for detecting form focused keratoconus are pretty similar. And this figure actually has been shown before. So for the left one, it is actually a comparison between keratoconus and normal eyes. So you can see the CBI and the BAD actually has a very high and comparable AUC. And the right hand side is the comparison between keratoconus, form focused keratoconus with normal, and you can see the CBI and the BAD has also similar, around 50 to 63% sensitivity in detecting form focused keratoconus from normal. So therefore, it seems that we need more. However, we combine the tomography and also the corneal biomechanical properties in differentiating form focused keratoconus. So for example, in this case, you can see the right eye of the patient is totally normal, but the left eye has definite keratoconus. So when you do the TBI for the right eye with the seemingly normal eye, you can get a normal BAD, but very abnormal CBI of 0.94, and it generates a TBI of 0.98, which is very high in this case. So the Ambrosio group actually published similar findings. You can see on the right hand side, it is actually a graph comparing the subclinical keratoconus from normal. You can see the TBI has a very high area under curve, while the CBI and also the BAD has a similar finding than we do in the previous study. And in CUHK, we also perform some analysis, and we have 41 keratoconus case, 37 control, and 23 subclinical keratoconus. You can see those patients are quite comparable apart from the corneal thickness, especially for the normal and for the comparison between the normal and keratoconus suspect. And we find a AUC of around 9.925 for the TBI, and for the Pentacam it's only around 0.79. And this is the graphical representation. You can see the TBI is significantly better than the BAD in differentiating subclinical keratoconus from the normal eyes. So this is an example. So this is one of the patients, and so the cornea is a bit thin, but the tomography appears okay. And the BAD is okay, looks normal, but when we look at the CBI, it is in the red zone, and it generates a TBI of 0.62. And this patient actually, he came for for refractive surgery, and then I actually asked him not to do it or have observed for a couple of months, and. So usually in a typical patient, you will have a normal BAD, CBI, and normal TBI. And this is another patient, a seemingly normal topography, and the BAD is a lot of yellow. This is actually commonly encountered when you are screening for patient for refractive surgeries. And then we also test for the CBI, and then you can see that TBI is 1 in this case. So this is another case, and also we got a high CBI and a high TBI. So we believe that the combination of the corneal tomography and also biomechanical properties provide safer and more efficient refractive screening. And thank you.